part 1, we looked at local factors associated with endometriosis pain. And in part 2, we considered peripheral and cross-sensitization. In part 3, we're going to dive into my favorite topic, pain system hypersensitivity or central sensitization, and its effect on endometriosis-associated pain, what it is, how we can screen for it, and what we can do to change it. I'm Jill Mueller, pelvic health physiotherapist in Ontario, Canada. I have a passion for helping people with endometriosis, and you can check out my story in the video My Why that I'll link below. In case you've heard different terms, pain system hypersensitivity has been shown by the public to be the preferred term over central sensitization. You may also hear it called nociplastic pain, neuroplastic pain, and central pain, but all of these are talking about the same thing, the brain, and how it's involved with pain. Before we start, I want to reassure you that what we're going to review isn't you making up or imagining your pain. It isn't something that you've done, and it isn't your fault. The brain is involved in pain 100% of the time, and if you feel pain, it's real. You see, our brain is designed to protect us, and a sensitized brain is an overprotective brain. And spoiler alert, there are treatments that can change this too, but it isn't about unthinking pain. The system needs to be retrained and it cannot be cut out. So I'm going to encourage you to continue watching the video with curiosity and an open mind, and possibly even end up feeling a little more hopeful. Let's simplify the concept of sensitization. A typical nervous system can be compared to playing an acoustic guitar, where the input of strumming the guitar strings reflects the volume of output of music. So if you strum gently, the music is soft. If you strum more aggressively, the music is louder. A sensitized nervous system is like having an amplifier plugged in. The input is the same, but the output is amplified. Central sensitization can occur after continued or recurrent exposure to danger messages. When it comes to endometriosis, this can be irritated endometriotic tissue and local nerves, inflammation, and local immune responses that continuously stimulate the nerve receptors in the spinal cord. And these receptors at that spinal cord level can themselves become overly sensitive, allowing an amplified signal to be sent up to the brain. And/or changes in the brain can affect the calming or dampening messages the brain can have, communicating back to the spinal cord and eventually the tissues. Both of these situations causing an increase in pain response. Some people have these changes in the brain already, priming the nervous system to be sensitized and vulnerable to pain as an output. This is where adverse childhood experiences and trauma may set up changes in the brain, causing it already to be on high alert. Now, we don't have a pain center per se in the brain. Threat or danger messages are sent to the brain, where areas that store memories, emotional centers, and our personality centers all get involved in interpreting this incoming information. A study by Asani and group in 2015 used a functional MRI of the brain in people with endo-associated pain and compared them to those with endo and no pain and healthy controls. They found that people with endo-associated pain have an increased resting state communication between the pain processing regions of the brain compared to those with endometriosis and no pain and healthy controls. This just means that their brains weren't ever turning off or resting. Their brains were constantly on the lookout for threats and analyzing incoming data. Sounds exhausting, doesn't it? In another study they did on people with endo-associated pain, they found less gray matter in regions known to be involved in pain processing and modulation. And similar brain findings were found in people with chronic pelvic pain without endometriosis. However, not found in people with endometriosis without pain. In fact, this group showed an increase in gray matter volume in the area of the brain that helps to modulate or calm pain and regulate emotions. They concluded that changes in the area of the brain involved with pain processing play an important role in the development of chronic pain, regardless of the presence of endometriosis. But before you panic because you think this is you, remember what I said in the beginning, that this is all changeable. So stick with me, you're doing great. These findings may help people who don't respond to medication and or surgery, interventions directed at treating only local factors, to understand that although changes can be found in the head, in the brain, they are not in fact making up their pain, and that their pain is real. Some researchers have postulated that these brain changes might also contribute to other common findings, such as mood disorders like anxiety and depression, and cognitive impairment like trouble focusing and foggy brain, because these are the centers that are lit up and never at rest, as seen on the functional MRI. So whether we have pre-existing mood disorders or develop them because of brain changes due to our pain, they aren't helping each other. And for some, directing care towards mood disorders may help chronic pain. Depressed mood, anxiety, worry thought cycle, pain anticipation, and increased attention to pain are associated with higher pain intensity. Evidence suggests that psychosocial factors impact pain processing at all levels, local, peripheral, and central. The good news is, addressing the presence of any of these can impact a person's experience with pain. The process of pain system hypersensitivity may explain why some suffer from painful periods and or persistent pelvic pain, but have very little or even no identifiable disease, while others with a lot of endometriosis experience little if any pain. In most people, most of the time, peripheral and central sensitization are temporary and adaptive. They prevent people from doing more harm to damaged tissues and ultimately motivate them to get help. But what if that amplified sensitivity persists after people have had surgery, after they're healed, or even in the absence of any detectable tissue damage? This contributor to pain can't be cut out, nor responds to hormonal and anti-inflammatory medication, and may explain why up to 50% of people continue to have pain after endometriosis surgery. Pain system hypersensitivity needs to be addressed differently than how the medical system is currently addressing pain. We need to be addressing this alongside medical treatment to improve someone's outcome post-surgically, and this is what is being suggested in the research. Natasha Orr and research group out in British Columbia, Canada, identified that the Central Sensitization Inventory, a validated questionnaire, can be used with the endometriosis population to identify people with pain system hypersensitivity. They found that higher scores at baseline were associated with worse pain outcomes after endometriosis surgery, and deduced this may be why some people don't respond to current endometriosis treatments. They also found that a high CSI score is correlated with higher chronic pelvic pain, pain with deep penetration, painful bowel movements, and low back pain. What they propose is that instead of our current treatment path for those with endometriosis, it should perhaps look like this. If you want to do the validated short form of the test, which is only 9 questions, press the link I've included below. I'll score it and email you what your score means and what you can do to get started. In the meantime, here are some other indicators based on research that you may have pain system hypersensitivity. The more you have, the higher the chance of central sensitization. Persistent pain greater than 3 months, exhaustion or fatigue, sleep problems, pelvic floor tenderness, abdominal wall tenderness, dizziness, cognitive problems, worry thought cycles, psychological indications, pain with normal touch, pain increased with stress and better when you're feeling good or on vacation, inconsistent pain or widespread pain, pain that started on one side and now is on the other side, and not responding or short-lived relief to surgery, medications, or other therapies, including traditional pelvic physiotherapy. Or if you have any of the following syndromes, like fibromyalgia, chronic fatigue syndrome, migraines, jaw pain or problems, irritable bowel syndrome, bladder pain syndrome, or sometimes called interstitial cystitis, vulvodynia or vestibulodynia, vaginismus, and complex regional pain syndrome. In conclusion, continued pain after endometriosis surgery, especially excision surgery, does not necessarily mean that they've missed the disease and that you have endometriosis growing back. Not responding to medications and experiencing all of the listed side effects doesn't mean that your endometriosis must be all over and taking over your body. Pain has more factors it considers than just the local tissue, and these factors may be the missing link when we're considering someone's pain experience. There are many mechanisms and interactions between the periphery, so what's going on inside the body, and the central nervous system, the brain and the spinal cord. And in people with endometriosis-associated pain, studies show alterations in both the peripheral and the central nervous system. The good news is we can determine if central sensitization is a factor to someone's pain. And if it is, treatment needs to be directed at treating that, which is all changeable. So take the test, follow me on Instagram, and join my online community in the link below to learn more about how to address pain outside of the local endometriotic tissue. Change can happen. We just have to direct our treatment to the right source.